Forum. I am extremely pleased. I have a background in public health. I have a master in public health and focused on social determinants of health. So this is an extremely important topic in that realm. And to introduce our panel and moderator for the day, I will bring up Lindsay Baker of League of Women Voters of Santa Barbara.
We would like to thank the Santa Barbara Public Library for co-sponsoring this forum with our League of Women Voters. Also, thank you to Gary Atkins, Sound Systems, and Sylvia Uribe for Spanish translation. I would like to thank Dick Jensen for organizing this forum. He has been associated with Planned Parenthood here in Santa Barbara since 1968 and was Assistant Chancellor at UCSB. And he is a member of the League of Women Voters Ed Fund Board. Some announcements. The state of California is supporting an initiative to be on the ballot. Today, Linda Phillips, please stand, Linda, has some sign-up sheets regarding this initiative. You have some flyers on your seats, and she has some additional flyers for more information. This initiative will restore up to $11 billion per year to California schools, community colleges, health clinics, and other vital local services. It will close the corporate property tax loophole in Proposition 13 while continuing to guarantee protections for homeowners, residential renters, agricultural land, and small businesses. Any day now, the State Attorney General will give the initiative its official title. It is currently called the California Schools and Local Communities Funding Act of 2018. And we will be able to start circulating the petition in about a week. We will have only 2 months to gather signatures. Please help us gather signatures on the petition or volunteer to help the campaign in other ways. Look for a sign-up sheet at the back table or look for Linda, and others will be happy to help you sign up. You do not need to be a League member to help us with this. Thank you. And Dick Jensen. The State League of California is supporting it.
Hello. We're fortunate, in spite of the parking, to have 3 outstanding women speak today about reproductive rights and health. They are, in the order that they speak, Laury Oakes, a professor of feminist studies and a PhD out at the university. Vaughn, even though it's spelled Van, Vaughn Do-Reynoso, who is also a PhD, who's the Director of Public Health for Santa Barbara County. And Jenna Tosh, PhD, Executive Director of Planned Parenthood of California Central Coast. As you have seen in the announcements, the League of Women Voters adopted an 83 positions on reproductive choices. And that reads, the League of Women Voters of the United States believes that public policy in a pluralistic society must affirm the constitutional right of privacy of the individual to make reproductive choices. In 1983, those words were different than the world we see today. I asked what was meant, and others have asked me what that meant. And the answer typically is about birth control and abortion. As you will hear, we need to understand a broader range of concepts than those. Medically accurate, complete education is a key element. As you will see, much of the conflict is about information as well as practice. Our speakers begin with a broad view of the issues and narrow down to public health and aspects in our area, and finally describe a set of practices relating to our topic. We're grateful to their speakers for their efforts. We've passed out cards so that you may write any questions you have and submit them, and we'll pick them up from time to time. I'll read the questions so that our partners at TV Santa Barbara and the Spanish language interpreter can hear the words. Laury Oakes, PhD, is the chair of her department in feminist studies and the author of many books and articles. She's been at UCSB since 1968, or 1998. Mercy. I was there since 68, yeah, at least. Her interests in reproductive health and education are not just academic, since she's the mother of a ninth grader. Laury Oakes.
Thank you, Dick. And I first want to thank Dick for organizing the event, and I want to thank all the others who I know are acting behind the scenes to organize us today, and thank you all for taking out time in your day. I think that it's a really important time for all of us to be thinking about reproductive politics, and I really enjoy the panelists and how we work together here. So I am going to, in 20 minutes or less, talk to you about the 1970s to the present. I should say that when I teach this at UCSB, even a 10-week quarter isn't enough to cover all of this, so I'll do my best here. So as Dick has said, the League of Women Voters national position was set out in 1983. I want to emphasize here the emphasis on constitutional right of privacy of the individual to make reproductive choices. So what I want to do today is to present the political and social context for this 1983 statement and trace changes in reproductive health policy, law, medicine, and social movements, bringing us up to the present with a shift from the concept of reproductive choice to movements for reproductive justice. So as you can see here, I see this as a dynamic change over time, and there has been, since the late 60s really, an enormous amount of attention by scholars, interdisciplinary scholars. I want to give you just a few book covers here. I really want to draw on research by interdisciplinary and feminist scholars of history, sociology, law and society, and public health to assert that arguments centered on the language of choice is not and has never been complex enough to meet the needs of women and girls in our society. So if you have free time, this is excellent reading, and I sure wish that I could teach this year-round at UCSB. So I want to turn next to talk about how the League of Women Voters 1983 statement is really based on what happened 10 years previously. So drawing on the US Supreme Court ruling in Roe v. Wade in 1973, we see that in the popular imagination, even today, that the Roe decision protects a woman's right to choose abortion. Roe established a woman's right to privacy following the 14th Amendment and implemented a trimester-based regulation system. Many of us are so familiar with that trimester system, we don't realize that it wasn't implemented until 1973. So previous rulings on contraception, first for married women in 1965, later for all women in 1972, also centered on this privacy rationale. And some of you might look at those dates and say, wow, that wasn't that long ago, really. So pushing for and celebrating Roe v. Wade were the National Organization for Women, the National Association for the Repeal of Abortion Laws, Planned Parenthood, World Population, medical professionals who were treating women for self-induced terminations, and underground networks. One, for example, of ministers and rabbis called the Clergy Consultation Service, and another of feminists who were working in Chicago called Jane. Those who were arguing against abortion rights included the Americans United for Life, which was founded in 1971, so note that's previous to Roe v. Wade. So activists were really building up and knowing that Roe v. Wade was coming. Some of the states had already legalized abortion rights. The first March for Life was held in 1974 and continues, of course, as we see annually, to energize the anti-abortion movement. The Catholic Church, in addition, has been a main anti-abortion advocate, other religious organizations too. And in the run-up to the Roe decision, additional abortion restriction options were already being designed. In 1973, the same year as Roe, the Helms Amendment was enacted, banning foreign assistance funds to pay for abortion services, although it allowed for post-abortion care services. So I really want to underscore that also in 1983, it marks the investigations in Montgomery, Alabama into sterilization abuse. The case in 1973 featured Mary Ellis and Minnie Ralph, who were 14 and 12 years old at the time. Their mother, who could not read, had signed with an X her consent to what she thought was a birth control shot for her daughters. Both of her daughters had mental disabilities. Investigation into this poor Black Southern family's experience uncovered that actually federal funding was used to sterilize 100 to 150,000 low-income people annually. So this underscores that although Roe is most popular in our narratives about legal support for women's decisions to end a pregnancy, less attention has been paid to women's rights to become pregnant and to raise their children. So here we see the early seeds of the reproductive justice frameworks for understanding differences in women's lives. Only 3 years after Roe, in 1976, Congress passed the Hyde Amendment, sponsored by a vociferous anti-abortion Republican and Catholic senator from Illinois. I'm embarrassed to admit that is my home state, Henry Hyde. The Hyde Amendment, which is reenacted annually, banned the use of federal funds for abortion care, with the exceptions to save the life of the woman or cases of rape or incest. I should side note that that is drawing on some Catholic ideologies. Modifications, however, even narrowed the exception to only save the life of the pregnant woman between 1981 and 93. The Hyde Amendment directly penalizes millions of women and girls receiving Medicaid, 1 in 5 of reproductive age, according to Planned Parenthood. It also penalizes their health care providers. Low-income women, many of them women of color, are subject to this ban. Other women are denied the protection of Roe, including military families, Native Americans, Alaskan Natives, federal prisoners, and yes, even Peace Corps workers. The Democratic National Committee platform in 2016, as you know, called for a repeal of the Hyde Amendment, linking this to support for Planned Parenthood clinics in the face of Republican defunding efforts. So this brings us to the focus of the 1980s, and this is a really busy slide because a lot was going on in the 1980s regarding women's reproductive rights. So threats to women's access to affordable and high-quality abortion care expanded in the 80s, gained visibility, and introduced violent tactics. In 1980, the Republican platform introduced a fetal rights constitutional amendment, which failed, but other strategies have clearly prevailed. At the same time, Reaganomics and the New Right worked together to undermine welfare safety nets. Clinic sidewalk and state abortion laws, hundreds of them were introduced in each year in many states, are battlegrounds. So we see direct attacks on clinics and providers, as well as policy. Anti-abortion movement leaders pitted the pregnant woman versus the fetus, which they call an unborn baby. Medical advances and imaging technologies were used by these activists to demonstrate this argument, and it was an attempt to persuade the public that unwanted pregnancy should be endured. This extended beyond the US. In 1984, the Reagan administration implemented the Mexico City policy, better known as the Global Gag Rule, and currently called Protecting Life and Global Health Assistance. It prohibited and prohibits overseas aid to organizations providing abortion care, doing counseling or education, and to anyone who would even basically say the word abortion. Women and families in the global south have been denied family planning, HIV/AIDS, and maternal and child health care on the basis of this policy. The abortion rate has not decreased, if that indeed was the goal, and the global gag rule is a part of political theater, being overturned by Democratic presidents and being reinstated by Republicans. It is not a coincidence that the backlash against women's rights, civil rights, and consumer rights movements transformed into the politicized and polarized culture wars in the 1980s and into the 90s. So we see in 1992, the US Supreme Court in Planned Parenthood of Southeastern Pennsylvania versus Casey rejected the trimester framework that Roe had put in place to focus on fetal viability. Note this links to the fetal personhood arguments that were being set up in the 1980s. This opened the door for states to restrict abortion even in the first trimester, as long as the measure does not create an undue burden. And I love this poster here because the status of this undue burden measure is subject to wide definition and disagreement. States have implemented mandatory ultrasounds, waiting periods, inaccurate medical counseling, banned non-surgical abortion, and passed trap laws to force clinics to close when they cannot comply with unnecessary renovations. So the movements to restrict abortion rights achieved a major goal in the 2000s, in 2003, when President George W. Bush signed the Partial Birth Abortion Ban Act. The language of this act is not based on medical procedures, but instead is language promoted by the National Right to Life Committee. It was upheld by a 5-4 close vote in 2007 by the US Supreme Court in Gonzalez versus Carhart, and clearly politicizes medical decisions. The extremist wing of the anti-abortion movement continues a crusade using violence and disruption of abortion care. The National Abortion Federation tracks thousands of incidents each year, including online harassment, clinic blockades, bombing, arson, assault, vandalism, attempted murder, and since 1990, 11 murders. I urge you to go to the NAF, the National Abortion Federation website, and look at their statistics. How can we find energy to continue to face this violence as we must attend to the relentless political attacks beyond California and at the national level? Congress prepares to vote on a nationwide ban on abortions at 20 weeks, shutting down options for women and their doctors at a time of extreme medical need, and showing that there is an idea that the government has to display anti-abortion loyalty. This is a time to raise our voices, to act creatively, and to form coalitions. So to end on a more positive note, I want to turn to look at reproductive justice as a way to understand reproductive rights and health. Scholars and activists emphasize that the reproductive justice movement's focus is explicitly broader than pro-choice activism. Sister Song defines reproductive justice as the human right to maintain personal bodily autonomy, have children, not have children, and parent the children we have in safe and sustainable communities. So at a time right now, we are thinking about gun violence in our communities, and reproductive justice takes that into account too. So any of the major pressing issues in individuals' lives and communities will be a part of a reproductive justice focus. So the reproductive justice movement's attention to broad and intersecting reproductive and social issues draws on activism by Black, Chicana, Indigenous people, and women's health movements, the consumer rights movements that were starting in the 1960s. I hope that some of you know the book, Our Bodies, Ourselves, that is in its umpteenth edition. That's from the women's health movement. They all focused on the social, medical, and economic constraints on the pregnancy and parenting decisions available to families of color. The term reproductive justice itself was first put forward in 1994 at the Black Women's Caucus meeting held at a pro-choice conference in Illinois with the aim of connecting US and global women of color activism. So that year, global women's health advocates were mobilizing for women's rights as human rights at the International Conference on Population and Development in Cairo. With Ford Foundation funding, members of 16 women of color organizations met to bring together the Sister Song Women of Color Reproductive Health Project. So I want to point out that their early work was designing a research, education, and leadership program on reproductive tract infections, which are linked with infertility and are disproportionately affecting women of color and low-income women because they don't have access to care. Using a human rights movement framework to improve the well-being of women of color explicitly for them meant addressing the human rights violations of poverty, homelessness, and inadequate health care. The collaboration shaped the Sister Song Women of Color Reproductive Justice Collective, that's a mouthful, an umbrella organization based in Atlanta with the mission, quote, to strengthen and amplify the collective voices of Indigenous women and women of color to achieve reproductive justice by eradicating reproductive oppression and securing human rights. So I want us to think seriously about how the reproductive justice concept, which is a theory, a strategy, a set of practices, honors the decisions that men, women, gender non-binary, transgender individuals make about their own bodies and lives, and also set those experiences within the options that are available to families and communities. This framework then motivates us to focus on how power operates. US policies have not been evenly applied to all people. We need to take into account that appeals to the privacy discourse and the idea of choice does not reach the realities of the majority of low income and women of color or address basic disparities in our society. Reproductive justice activists, in coalition with allies, provide dynamic ways to enhance our understandings of reproductive rights and health. Thank you.
Do-Reynoso is also a PhD and a relatively new Santa Barbara resident. She's Santa Barbara County Director of Public Health and also 17 years the director in Tulare County and Central Valley. So she too is the mother of a local 8th grader whose primary choice seems to be making the right high school choice for the next year. Vaughn?
Thank you, Dick, for the warm introduction, and thank you, Laury, for setting the context for our discussion this afternoon. So I'm a talker, and I wish we had the rest of the afternoon for me to just share with you the wonderful work that the Public Health Department is doing and will continue to do in order to support women and teens and children. But given, I was given strict instructions by Dick to keep it under 20 minutes. In this brief time, I will focus on one program in our department, the Maternal Child Adolescent Health, and how this program partners with the community and the women and the clients that we serve in order to achieve the best outcome possible for their families. So, the Public Health Department promotes reproductive health through an array of direct services and case management services in the Maternal Child Adolescent Health Program. And it's funded by Title V, which is a federal block grant funneled through the state and local match. Our commitment, even though the federal dollars continue on the decline, as I'll show you later in the presentation, the local commitment is firm that we will continue services in order to ensure the health of our community. So the money comes through the federal to the state and down to the counties. And one of the basic requirements that the state gives local jurisdictions is that every 5 years we have to conduct a robust data-filled community health assessment. And not only do we take that data and sit in a room and come up with a list of priorities, but we have to take that data and engage community partners, engage clients, engage other service providers in order that we formulate a list of priorities, a list of services, tweaking what we are currently doing so that needs are met. So if you look across California, the 58 counties and the 3 local cities jurisdictions, you'll see some flexibility depending upon local needs. So our last needs assessment was done in 2015, and so it is available on our website, as is the previous needs assessment. So if you like data like me, you will find really good information on our website. So the scope of maternal, child, adolescent health services in Santa Barbara County. We're not only governed by the data, but the state also asks that we conduct the work keeping in mind some broad paradigms. And it's a different take on what was perceived traditional. So the traditional way of delivering public health services or case management services really focuses on changing individual behaviors. And so with the 10 essential services of public health, with the spectrum of prevention, the life course perspective, the social ecological model, the social determinants of health, and the strengthening families, really moves us away from the belief and the perception and the practice that in order to impact health, in order to raise the needle, if you will, on health, we have to concentrate on the individual. It's moved beyond that to looking at what socioeconomic and political structures are existing that impacts the woman, that impacts the family, that impacts the child, the infant, or the teen. So it's looking at assessing the data in the environment and working with partners, working with policymakers, working with funders to impact institutional and impact policy changes. So, and the Strengthening Families is a really neat program. It's internationally recognized as an evidence-based program that if we implement and work with our families, that the resiliency and the protective factors in the families will greatly decrease the risk factors of entering into juvenile justice, of child abuse, and increases the likelihood of success for that child and that family. So not only do we case manage women and teens, but we also build their capacity to learn some healthy parenting skills to build their capacity as well. The scope of our services, when we talk about increased access and utilization of health and services, we mean to make sure that the clients have access to oral health services, and these are all driven by data and by community engagement. Making sure that there are access to mental health and substance use services, making sure that the families have access to preventive health services and have mechanism to utilize those services. We do target outreach services to identify pregnant women, women of reproductive age, infants, children, and adolescents, and their families who are eligible for Medi-Cal assistance and other publicly funded programs. We make sure that the families have an opportunity to utilize developmental screening for all children so that we can align the appropriate services or make linkages to the appropriate services. We also look at improving preconception health by decreasing risk factors for adverse life course events among women of reproductive age. By this, our work really is to decrease unintended pregnancies, decrease the burden of chronic disease, decrease the instance of intimate partner violence, and assure that all pregnant women will have access to early adequate and high-quality prenatal care with special emphasis on low-income and Medi-Cal eligible women. We also work consistently to reduce infant morbidity and mortality, and we do that by making sure that all the new moms in our program know about safe sleep practices for their infants. And we really partner up with practitioners, hospitals, physicians, and community agencies to promote breastfeeding initiation and duration. We also look at increasing consumption of healthy diet and physical activity because we know that healthier women need to have access to the healthy diet, need to have access to this physical activity. We improve cognitive, physical, and emotional development of all children, including children, youth with special healthcare needs. So looking at reducing unintentional injuries, looking at reducing child abuse and neglect, and again, making sure that all children have access to developmental screening so that we catch issues early on. And in terms of adolescents, we work our programs through case management and direct services, seek to decrease teen pregnancies and reduce teen dating violence, bullying, and harassment. So now the fun part, data. In 2015, we registered 5,673 births. So of this number, roughly rounding up, 65% were Hispanic, followed by 28% whites, followed by 4% Asian, and 2% multi-race. Blacks and American Indians were each less than 1% in our county. So what does this mean? What's the significance of sharing this data? Why do we collect it? The breakdown is important for us because we need to make sure that our programs, our services are developed to meet the needs of specific communities. The trends in teen birth rates. I'm sharing this with you because it is a cornerstone, one of our foundations of MCAH. Teen birth rates in Santa Barbara County reflects the national decrease in rates. So our teen birth rate decreased in 2016 to 16.8 from 19.7 births in the preceding year. And so if you look at, say, 2012, we were at 28.2. So that is reflective of the national trend in the downward slope. And that's a good thing. That's a very good thing. So, but the work is not done. We still need to do work around that because early childbearing remains a public health issue as long as there is a rate. And monitoring birth data among adolescents helps state and local efforts to identify areas of greatest need for support and program services. The data helps us understand trends over time. It demonstrates our successes as well as challenges and what needs to be improved in order to even achieve greater decline. And of course, as you are aware, teen birth rates are influenced by social, by economics, and by individual factors. On a national level, evidence suggests that birth rates are declining largely because more youth are using contraceptives and more youth are having access to contraceptions as well as appearing to be delaying in sexual activities. We in public health like to say that public health prevention, evidence-based education, and support programs are working. And we need to continue to advocate for public health prevention, for evidence-based education, as well as support of that teen. And we are increasing outreach around rights and improving access, making sure that when youth want it, when they need it, they will have access to reproductive health services. And so all this in combination, I believe, have decreased our teen rates. So locally, wanted to give you a snapshot, even though the rates are cleaning, what percentage of our teen birth rate in context of total birth. And you can see that's only 6.7%, but that still is roughly around 400 births being given by teens. So infants of teen mothers, just want to briefly go over why that's a concern to us, the teen birth rate. Infants of teen mothers are at higher risk for physical, social, and emotional challenges than infants of mothers in their 20s and 30s. Giving birth as a teenager also can create disadvantages for the mother and the father. Teen mothers are more likely to become dependent on social services than their peers. Teen parenthood for both mothers and fathers is associated with lower educational attainment and lower income levels. But the bright thing is, with support, with social support and case management services, these teen parents are able to manage their challenges successfully and will achieve a greater success than teens who are not. And so research also estimates that teen births cost society billions of dollars annually, most of which is associated with negative outcomes for the children of the teen parents, including increased costs for healthcare, foster care, incarceration, lost productivity, and of course, tax revenues. So when you look at teen birth rates in our county, where are they taking place? Our data shows that the proportion of teen births are higher in the north and the mid-county than they are in South County. Why is this important? It's important because it informs us where resources need to be allocated. Given the limited resources available, where will we need to place the available monies, the available staff, in order to make the greatest impact on teen pregnancy? So this gives you a broader scope of where we land compared to the state. This is a graph of birth rates by counties, female age 15 to 19 in California. So the dark line is the state average. We're about 3 lines below that. So I am not a competitive person, but I noted that our neighbors, SLO and Ventura, are above the state average in achieving that. And so our work is cut out for us. It's noteworthy to point out to you that the counties with the highest 3-year aggregate birth rate, it's about 6 times greater than the county, Marin, with the lowest aggregate birth rate. Marin is also a very well-resourced county. And since Dick mentioned to you that I came from the Central Valley, most of the highest birth rates happen in the 8 counties with the greatest number of people living in poverty or below poverty. So socioeconomic status does play a role in teen birth rates. Disparities in reproductive health. So health disparities refer to differences in health status of different groups of people. Some groups of people have higher rates of certain diseases and more deaths and suffering from them compared to others. And these groups the health disparities may be based on race, ethnicity, immigrant status, disability, sex or gender, sexual orientation, geography, and income. And we see health disparities here in the rates of chlamydia, gonorrhea, and syphilis. The sad thing is that all these are very common bacterial infections that are easily treated with antibiotics. Chlamydia, untreated, can cause serious permanent damage to a woman's reproductive system, which may make it more difficult, if not impossible, for her to get pregnant later on or experience serious complications during pregnancy. So when we talk about reproductive health, we want to make sure that women have access to the diagnosis and access to the treatment. So for the chlamydia, we see a disparity based on gender and ethnicity. Gonorrhea is very common, especially among young people, ages 15 to 24 years. And again, here we see disparity among age and ethnicity and gender. Syphilis, same thing. We see women of reproductive age getting infections, and this has serious implications because we want to prevent congenital syphilis, and that is when a woman with syphilis passes it on to her fetus. So why are we concerned when we talk about reproductive health? Why are we concerned about the increasing STDs? Because STD prevention is an essential primary care strategy for improving reproductive health. It is the whole low-hanging fruit, so to speak. It is treatable with access to services. STDs remain a significant public health problem in the United States because of their high rates, because of the burden of costs related to the disease and the complication, and the fact that they are, again, largely preventable. But you see, it's not yet recognized. It's recognized by everyone in public health or providers, but it's largely unrecognized by the public, the policymakers, because we don't see an increase in funding to address the prevalence of STDs in our country. And we know that STDs prevention will be the most effective way to combat the rising rates, because STDs can cause harmful, often irreversible, and costly clinical complications as infertility, fetal and perinatal health problems, cancer, and other infections. Okay. So let me move on to prenatal care as reproductive health. So this is a snapshot of how many women in their first trimester were able to be in prenatal care. So the numbers are pretty good, but we can definitely improve. And again, here you see some disparity based on race and ethnicity. So overall, of the number of women who gave birth, we had 77.5% able to access prenatal care within the first trimester. And if we improve this rate, we will improve outcomes for the moms as well as for their babies. Okay. Insurance status of mothers, 2015. We have proportionately a bigger number, 60%, of the moms being on Medi-Cal, eligible for Medi-Cal services, as well as about 40% non-Medi-Cal. So why is this important? It's important to track this data because, again, insurance status is a tipping point for us. It tells us, it informs us the type of services that may be needed to support the moms and their infants after the birth event. What types of social services might they need? What type of parenting services might they need? What type of mental health services might they need? Another slide to share with you about the health disparities. So maternal mortality. And the good thing is that this is a graph that shows the US rate as well as the California rate. The reason why Santa Barbara's rate is not on this graph is because it's 0. So we had one instance of maternal mortality in 2014 of the live births that were recorded. This is a concern in public health because we as a country have the worst rate among developed countries. And California is able to achieve a decrease because we have made sure that public health is implementing evidence-based practices, outreach is happening, and practitioners are embracing new innovative treatment. And the acknowledgement that race and ethnicity does have a play in it. Black women are 4 times more likely to die than white women. So acknowledging that there's disparity helps us, informs us the types of treatment, the types of outreach, and the types of case management services that are needed. So impact of funding to maternal child adolescent health programs. This is a study done by the Los Angeles County Public Health. So what we see is that it's statistically significant. There is statistically significant association between funding and each of the 3 outcomes that we talked about. So when we have a decrease in MCAH funding, we see an increase in low birth rates, we see a higher rate of infant mortality, and teen birth rates as well. And so again, the funding continues to decrease, and it has been decreasing for the last 10 years and will continue. So the big question is, how do we mobilize our funders at the state level, at the federal level, and how do we continue the community engagement to ensure that local programs continue to exist? I want to end on a bright note. Future plans. We are embarking on building our services to ensure reproductive health. So we note that STDs are on the increase. So we have plans to build a health promotion unit, leveraging resources with our partners so that we target our efforts to make the most impact. We note that adverse childhood experiences can really inform us on how to better deliver services to our families. So we will embed that across the department and partnering up with community agencies to do that. As I've shared with you, there are health disparities geographically and among age groups and among race and ethnicity. So that is on our forefront, looking at our delivery of services and tailoring it to make sure, again, we can make the most impact with the limited resources. And embracing that health equity is an opportunity for all of us to really look at what is it that specific communities might need and who are our partners so that we together can be a stronger and healthier community. Thank you.
Thank you, Vaughn. Our third PhD is Jenna Tosh. We have a well-educated group here today who moved to Santa Barbara 3 years ago to head the local Planned Parenthood affiliate. And she was the CEO of the affiliate in Orlando, Florida, before that. Her son attends a local elementary school, and her young twin daughters might be looking forward to that when they're of the choosing age. Jenna Tosh.
I don't know if they're looking forward to it, but I sure am. Good afternoon. So, thought I would start with our mission statement. As the most trusted provider of reproductive health care, we promote the ability of all individuals to lead fulfilled lives. build healthy families, and make informed decisions through high-quality health services, education, and advocacy. Yes, the clicker. Oh, thank you. There it is. So I thought I would continue some of the themes that we've heard today by just reflecting a little bit on when and why Planned Parenthood was founded. So Planned Parenthood opened the nation's first birth control clinic in 1916. Our founder, Margaret Sanger, was called to do this because she had watched her mother suffer and die at the age of 49 after enduring 18 pregnancies and 11 live births. And she was determined to pave the way for a future in which women could control their own fertility and by extension their own lives. The first day Margaret opened that clinic, women lined up for information around the block with their young children in tow, and that's an actual picture of that day. For the past century, Planned Parenthood has transformed women's health and empowered millions of people worldwide to make informed health decisions. Planned Parenthood was founded on the revolutionary idea that women should have the information and care they need to live strong, healthy lives and fulfill their dreams with no ceilings and no limits. And over the past 101 years, we've worked alongside our partners in the reproductive justice movement toward a world in which all people have access to effective and timely reproductive care. Today, 1 in 5 American women have accessed care at Planned Parenthood at some point in her life, and we see growing numbers of men as well. And of course, birth control, which was once out of reach, illegal, is widely available, and abortion, which was once a crime, is safe and legal too. And Planned Parenthood, once a single brownstone in Brooklyn, has 650 health centers across the country. This is our local map. In Santa Barbara, Ventura, and San Luis Obispo counties, Planned Parenthood California Central Coast operates 6 health center locations. And collectively, these centers provide nearly 35,000 patients each year with high-quality services, including breast and cervical cancer screenings, birth control, well-person exams, sexually transmitted infection testing and treatment, vasectomy, and safe and legal abortion. And our movement has continued to advance care. Because of the Affordable Care Act, over 55 million women now have access to contraception with no copay. And the ACA also ensures that preventive care, including women's and reproductive health services, such as breast and cervical cancer screenings, are provided without a copay as well. Emergency contraception, which is commonly called the morning after pill, can be taken up to 72 hours after unprotected sex to safely prevent a pregnancy. And it is now available across the United States with no prescription. And more women, including many teens now, are using what's known as long-acting reversible contraception, or LARC, including birth control implants and intrauterine devices. And this is significant because these are the most effective forms of birth control. Across the Central Coast, 22% of our Planned Parenthood birth control clients are now choosing one of these effective methods. And you heard Vaughn talk about the success of all these efforts, right? Teen pregnancy rates are on the decline. And in fact, teen birth rates and teen pregnancy rates are at historic lows in the United States. Between 1991 and 2015, teen birth rates dropped 64% in the United States, falling 74% in California, which makes California ranked 3rd for the fastest reduction in teen pregnancy rates across the country. And despite the continuous debate over the legality and access to abortion, the rate of abortion is actually at its lowest level since Roe v. Wade. But there is more work to do, despite all of these positive trends. Although teen pregnancy rates are at an all-time low, US teen pregnancy rates are higher than other industrialized nations. So I don't know if you can read all those names of those countries, but in contrast to countries like Australia, Ireland, Denmark, and Singapore, the US is still significantly higher. And disparities persist. Unintended pregnancy rates among Black and Latinx women are over twice as high as for white women. And unintended pregnancy rates vary greatly by location. Even here in California, where we have supportive policies and we've done a lot of work, 45% of all pregnancies are unintended. I'm surprised nobody groaned. Okay, so the surprise, right, sort of shocking 2016 election made Planned Parenthood a direct target. And it was pretty shocking because we were celebrating our 100th year of providing care and education in communities across the United States. And we had elected opponents of not only safe and legal abortion, but of accessible birth control. And after the election, of course, we knew that we were in for a fight and that we were going to have to fight to protect the Affordable Care Act, birth control with no copay, funding for fact-based comprehensive sexuality education, and safe and legal abortion. And of course, we all know that one of the first things the administration tried to do was defund Planned Parenthood. And I always like to explain or clarify that Planned Parenthood is not a line item in the federal budget. Paul Ryan, I think, has a fantasy of us getting a big publisher's clearinghouse check or something. What actually happens is that patients who have Medi-Cal or another government-funded health insurance come to Planned Parenthood and receive care, just like any other healthcare provider, and Planned Parenthood is then paid for that care, and we bill. And so it's very similar, if not exactly the same, as any other healthcare provider or hospital in the United States. And for many of our patients, Planned Parenthood is their only healthcare provider. So defunding Planned Parenthood is in fact never been an attack on Planned Parenthood. It's not an attack on me, but it's an attack on the people that we serve, who are primarily low-income people, people of color, people living in rural communities, and very much so people who have few other options for care. In California alone, if Planned Parenthood would have been defunded, it would have impacted as many as 850,000 patients relying on Planned Parenthood, and many of our 115 health centers across this state may have been forced to close. But we fought back. Planned Parenthood supporters made over 250,000 calls into Congress last year. We held thousands of rallies across the United States. Who could forget the over 5 million people who marched at the women's marches the day after the inauguration? We made our voices heard, and Planned Parenthood's doors stayed open. And in fact, here on the Central Coast, we added new services. For the first time, we began providing treatment for syphilis in response to growing rates. And we also began offering groundbreaking new medications known as PrEP and PEP, which safely prevent HIV for people who are at a high risk of infection. And we have a lot to be proud of in California. We're very lucky to have many pro-women's health policies, so I just wanted to highlight a few. The Family Pact program is a program that covers family planning services for women and men with low income, including teens and undocumented folks. Using state funds, California's Medicaid program covers abortion for low-income women. The state requires private health insurance to cover abortion without exclusion or limitation, and we also protect the constitutionality of Roe v. Wade. Even in the case that the Supreme Court were to overturn it, abortion would remain legal in California. California also supports teens' rights to confidential medical care and comprehensive sexuality education. The California Healthy Youth Act mandates that students who receive sex education in schools must receive medically accurate and age-appropriate information, which of course is in contrast to abstinence-only programs, which are known to be medically inaccurate. And California voters 3 times defeated a ballot measure that would have threatened teen safety by requiring parental involvement in a minor's abortion decision. California also went on the offense against incorrect information provided to women in so-called crisis pregnancy centers. The FACT Act requires that women will be given information about California's public programs that provide family planning services, prenatal care, and abortion. And the FACT Act also requires that crisis pregnancy centers disseminate a notice to their clients informing the client that they are not in a licensed medical facility. And California is going to defend the FACT Act before the Supreme Court. So last year, Quinnipiac University conducted polling which found that in spite of sort of this toxic, poisonous political environment, support for safe and legal abortion is actually at an all-time high. 91% of Democrats, 70% of independents, and 43% of Republicans support the Roe v. Wade decision. Most Americans do not want Planned Parenthood defunded. In fact, 80% of people oppose defunding of Planned Parenthood once they understood that no federal funding is for abortion services. And that includes 65% of Republicans. And I'll note, 49% of people who voted for Trump. And over the next several years of this administration, unfortunately, we do know that the attacks will continue. This administration quietly ended the teen pregnancy prevention program that funds sexual health education to reduce teen pregnancy. And Planned Parenthood affiliates in several states are currently suing the administration over this. And we know that this administration remains determined to defund Planned Parenthood. So we are going to remain vigilant, and we know that our 11 million supporters have demonstrated that they are ready to fight with us and for us. Thank you.
Thank you, Jenna. Okay, we have several questions, and I'll read them in the order they were submitted. What input will the new tax law have on the available funds for reproductive health services?
Of course, I think everyone knows that the tax law is going to create a very large budget deficit and add to the debt. So I think that is likely to have an impact on many programs in the United States, although I think we're not sure exactly what. And then, of course, there are new restrictions on charitable giving and tax deductibility of gifts, and it's pretty complex. We're not exactly sure at this point what the actual measurable impact will be on charitable giving, but I know that Planned Parenthood and lots of other nonprofit organizations are following the development of that closely.
Oh, go ahead, Vaughn.
I can say that maternal, child, adolescent health funding, we don't anticipate an increase anytime soon. So really it is up to the Public Health Department and its partners to be creative and pursue other funding streams. And as director, I have always believed in diversifying my portfolio for my programs. So really can't depend on the feds or the state, really. So looking at foundations, looking at local partners, and looking at local policymakers.
Thank you. Another part of that question is, what is the potential for the repeal of Roe v. Wade?
Okay, I'll take that one. I think the math on the Supreme Court justices hasn't really changed, right? Because Neil Gorsuch has stepped into the seat that was held by Antonin Scalia. So right now, looking at the math on the court, we believe we have about a 5-4 advantage on any direct challenges to Roe v. Wade. We do not think that Roe would be overturned with the current composition of the court. But of course, many of our most steadfast supporters of abortion rights in the Supreme Court are quite old, over the age of 80. And so we are concerned that this administration may have additional opportunities to fill Supreme Court vacancies, because that would have that could change the dynamic. Do you want to say more about that?
I don't need to say much more because I absolutely agree with that analysis. And one thing that when I talk to students at UCSB, they're very concerned about the fall of Roe v. Wade, but also we're in California, so we do have a cushion here that students, young women and women in other states don't have. So I think that I always want us to attend equally to the federal, the Supreme Court level, but also look at states' rights and how policies are chipping away the rights that we think that Roe has provided in many states.
Okay. Apropos of that, there's a follow-on question about how does Planned Parenthood plan to, what do they plan to do if Roe v. Wade is done? And along with that, a question was asked, how is it that California is different than the rest of the country?
Well, like Laury said, California is a place where there's a cushion, because we explicitly protect and codify the right to safe and legal abortion exclusive of federal law, which means that if Roe were overturned, California would be one of the states where abortion remained legal. And so the thing that would need to happen would be very similar to what happened pre-Roe, which is that women in states where abortion is not safe and legal would need to find safe transport to a provider in California or New York or one of the other states where abortion was legal before Roe and would remain legal after Roe. One of the things that I wanted to say in my slide presentation that I guess I just forgot to say, which is that medication abortion is quickly becoming the most common way for women to end a pregnancy. Medication abortion is 2 pills that are taken within 12 hours of one another, and it's safe, and it's a safe way for a woman to end a pregnancy at home. When Texas dramatically reduced the availability of abortion through TRAP laws, targeted restriction of abortion provider laws, and admitting privilege laws, there were huge swaths of Texas where women had no access to a surgical provider of abortion or a provider who could dispense medication. And research has shown that at least 250,000 of those women have purchased medication abortion from Mexico or over the internet. So I think it is important to remember that there are parts of the country where we really are already in a post-Roe type of an environment. California is not one of those places, but we do know that women already come to California as a sanctuary for safe abortion care, particularly women in the later gestation where they can't find a provider. And we would anticipate and have planned for California doing even more of that in a targeted and strategic way to meet the needs of women across the country.
Other comments? Okay, following on the 14th Amendment is a question or the assertion that the 14th Amendment prohibits unwarranted searches and seizures. How is the prohibition against abortion an unwarranted search or seizure? since a forced abortion would be that. And that's for Laury. Tricky.
Well, that's a good mind-bending question. I like that. I think that maybe we can look at the heart of the question is, what is the logic here? And I think that when we're looking at the polarization around abortion rights, that often there is no logic. So let's take, for example, the Hyde Amendment. The Hyde Amendment that prohibits federal funding for abortion care. Okay, anybody just think for a moment, what is the goal of that? It's to not provide abortions. However, it's for low-income women and who happen to be women of color in a society. So what is the result of that going to be? Yes.
The issue is class, and it always has been class, and availability of money. America's based on the buck, let's be honest, and it always has been based on the buck. So if you're wealthy and you have certain skills, you get ahead, and if you don't, you're shafted, very simply, and there's a double standard. So Trump is not going to wait around for that. He's going to, the Catholic Church and other institutions that are conservative.
Do you have a question?
Well, my question is, you know, the real threat is they're going to start put people in jail for birth control and for abortion. This is the threat that the right wing is doing. And if you don't think that's serious, look at what happened in Virginia with the fascist movement and the Confederates and the libertarian nutballs that are running the Republican Party.
I think you're now preaching to the choir. Was there a question in there?
Well, the question is that, do you feel that that's a real issue? Because, you know, while you're debating the details, the enemy is winning the war.
Yeah. I'm not sure you were listening, but does anyone want to speak to that? Yeah. I think they made a point that their enemy is winning the war. Yeah, let's put it that way. The Public Health Department, what do you do to focus on healthy families? Which outcomes are for health of teens, infants, children, etc.?
So we, in the Public Health Department, we have the 5 FQHCs where we offer a wide comprehensive set of clinical services for families. We have clinical care available for children, for teens, and for women. So that's the direct patient care that's available. And those visits, the health outcomes are determined and captured. We also, on the MCAH side, do the case management where we offer parenting classes, we offer developmental screening exams, we do case management and refer to services as appropriate. And we also have field nursing where we go into the home for high-risk infants, and make sure that the linkage happens between the provider and that family.
Thank you. There's an interesting question. How do you argue or discuss with an anti-abortion activist? How do you discuss abortion religious beliefs, i.e., life begins at conception? You may all want to speak to that.
So I think that's an excellent question. One of the things that we see in our society is that the discourses are so wide apart in public that it makes it seem that everybody is going to take one of these poles, but actually the majority of folks are somewhere in the middle. So I think it's a really important skill to have to talk to people across differences, not necessarily because your goal is to persuade somebody to think the way that you do, but so that you can come to a better understanding about diversity. One of the really interesting things is that in the reproductive justice movement, there are people who identify as anti-abortion. And this has been something that's really interesting for women's health activists because generally those folks all agree. In a recent volume that was published called Radical Reproductive Justice, there is a pro-life feminist who is one of the authors. And the editors of that volume really thought about whether or not they were going to include that. But indeed, because there are such diverse views on this, they decided to include it. So when I think about this idea of the polarization, I think discussion can get us beyond that polarization and open up different ways of thinking about what the main issues are. So maybe instead of thinking about abortion, you think about contraception. So there's a whole common ground movement in the United States that is doing exactly that kind of work.
I'll just add, I mean, we say all the time that when women come to Planned Parenthood, they're not making a political statement, they're coming for health care. You know, I think what we've learned over the past 45 years of legal abortion in this country is that the terms pro-life and pro-choice don't capture where the vast majority of people are. And we try to frame the conversation about personal decision-making and not judging women. I think that's really, you know, once you're in an argument with somebody and, you know, somebody's identified as pro-choice or pro-life, you're not going to make any more progress after that. But I think when you really talk about the importance of women making personal medical decisions in consultation with their families, their healthcare provider, in consideration of their own faith, and we're not that woman, we're not in her shoes. We need to make sure she has the support she needs. When you use language like that, we find that as many as 87% of people will agree that abortion is a personal decision and should be made free of government interference.
Well said. I have nothing.
Thank you. There was a question, may we have access to the slide presentation information from any of the speakers? And I should say, they've said yes. We'll clean it up, and if you'll send me an email, I'll send you a copy. But I'd rather have you also watch on Santa Barbara TV, which this will be in both English and in Spanish. And that's the reason we have a translator, is so that people who are watching it on video can understand what's being said. And we thank you, Sylvia, for your patience with us on that. So unless there are other pressing matters, that exhausts the questions we've received. And Lindsay, would you like to close us? Oh, she would not like to close us, so consider us. Oh, I'm sorry. Yeah, email me, and then you can't find out who I am. I'm djensen at silcom, that's SILCOM.com, and SILCOM.com.
My question is really quick. I was curious about the recent legislation that was comprehensive sex ed from K to yes means yes, but I think K to 12. And just, are you, Public Health and Planned Parenthood, are you seeing the beneficial results of that yet? Or has that been implemented? Or can we as citizens advocate for better implementation or checking our local school districts? You know, what can we do? What are you seeing?
So from the public health's perspective, 2 counties from Madera County and from Santa Barbara County. Here in Santa Barbara County, it's a process that can always be improved upon. And so we know that there are some questions on some topics that the school systems may not be comfortable discussing in depth. And so we are in partnership with several organizations to provide the technical expertise or input to Dropping the Mic effort. And we hope that through those videos, that timely, youth-driven, appropriate information can be communicated.
And I'll just add that I think it is often the case that very well-intentioned legislation can pass in a state like California that also amounts to something of an unfunded mandate. And I think the reality is that, like Vaughn was saying, a lot of teachers in schools don't have the capacity or the expertise to really implement that level of curriculum right out the gate. And so there have been a handful of meetings in Santa Barbara with community nonprofits, and Planned Parenthood's been part of that to help support the schools. And we also have been in conversation at the state level with our advocacy to make sure that when there are schools that cannot meet these mandates due to funding, that maybe there is some support in place for those schools. So, I think it was a outstanding piece of legislation and a really good goal, and we certainly support it. And we still have to, I think, do the work to make sure that it's a reality for all of our teens.
This time, there being no questions, no more questions. Thank you for your attendance and to our speakers for participating.